So we will open up for questions. Now, this panel really helped us understand. Are we all together? Okay, so so this panel really helped us understand a little bit more about what we need to do to communicate clearly about medicine in general. There was some discussion initially by Will Schrank about consumerism and differentiating services that are out there, and Dr. Shan Walther and Israelsky spoke about human factor analysis. As we wait for all the questions that are going to come up to the microphone in a minute, let me just begin with a question, a broad question related to the presentations. Does human-centered design differentiate you in the marketplace with the economic buyer, let's say, competitively, professionally, and what metrics would you use to determine that? I think Dr. Israelsky began that discussion by mentioning qualitative, quantitative analysis, and that learned from post-marketing analysis. But what's the broader perspective in terms of how it differentiates you in the marketplace? And again, what metrics can we use to determine that from broad perspectives?
I'll start. Well, there are a number of levels of metrics, I suppose, that might be appropriate here. One is that you succeed in the marketplace, people like your product, they adopt it, it helps them with their therapy, it helps them with their condition. This is recognized by healthcare providers, they prescribe it more often. Pharmacists see this and they're more likely to recommend that it be used. And then patients will ask for things that they feel are, so a glucose meter is a good example. People will gravitate to glucose meters that are easier to use, less confusing, have displays that are clear. If they track more complex things like meal marking, exercise, and all that, that they do that in a way that has good usability, and that will help them. So that the marketplace, that's probably a glib answer, but the marketplace is a big one. The other is compliance. You know, that's a big problem with medical products and therapy. We hear numbers like 40% of drugs aren't taken correctly. So the more you can do in applying human-centered design to the design of the rich communication materials, the supporting things like apps and websites, the more likely you're going to impact compliance and improve it and get it out of this terrible range of 40% of non-compliance. That will then create health and economics and outcomes research metrics that will see more control of diabetes and fewer people having to have downstream medical interventions that are more costly because their compliance early on allowed them to control their disease better, and that could go on for so many other diseases. That by good human-centered design, you are likely to impact compliance in a very positive way, directly through technologies like apps that remind you of things, or better packaging and labeling and risk communication materials so that people take their meds correctly, don't get stuck with the problem of interactions that lead to side effects because you've done a good human-centered design in communicating that to people.
Yeah, I mean, I echo what Ed says, and I think the first part of what he was saying sort of ties back to one of the broad themes that Will had touched on in his presentation, is the consumerism aspect and how that drives the marketplace, which I think is very important. Ultimately, if there are products that go out there that are creating problems, creating a lot of use errors or medication errors for patients, that is likely to impact patients' willingness to uptake, to use these products or recommend them to fellows consumers. You know, the other thing too is we get this question in terms of sort of driving the business consideration and the metrics, and Ed had sort of touched on this point about when we get into statistically powered studies in the human factors realm, we're talking about, of course, much larger studies, which are different from what I had described about typically what we see, which are smaller studies generally when compared to clinical trials. But there is research in this arena that does look at, how do we look at, for example, comparing products from a scientific approach in terms of patients' ability to use products, and then broadly within the FDA, we're focused on safe and effective use. You heard me use that term throughout, but within the realm of usability, there's much more that's considered in terms of marketing considerations, the business considerations, likability, which is also tested out there as well. So I think we're going to see more and more in this space, frankly, especially as sponsors become more and more interested about how that can impact their labeling in terms of labeling claims. So I think there's a lot that's on the horizon.
Great. James?
Hi, Jay Duig, member of the Roundtable. Thanks for the panel for being here today. I think this is a really interesting discussion following on the heels of this morning's patient panel. In the patient panel this morning, we heard very clearly their identification to be included in more, pardon me, of the resource development and the tool development process. And what we heard just described was one method, and a very systemic method, as Dr. Israelski and Dr. Chan described, for including patients in that process, developing data, and continuing to build off of it. So my question to both of you is around uptake, because I think you've both been very effective, Ed, through your work on the international standards committees, and Irene, through your work in DMEPA, is influencing wide groups of people that are creating materials. So how can we, from the Roundtable's perspective, do you have any ideas on the lessons learned of increasing the organizational uptake of this type of inclusion of patients within resource development? And Dr. Chan, of course, you have the FDA's regulatory authority, so which is very helpful. But in addition to that, and this was a very key point, so I think it's not what's been successful, and the agencies leading the example, is not just the performance of rote activities, but an embracing of the science and of the viewpoint and of getting at that why. Because we heard that why called out so clearly by the patients this morning, that they want that level of understanding. And when we're looking at the creating of written materials that include that type of meeting the patient's needs systemically. So I was wondering if you had thoughts on where organizations like the Roundtable can influence, to connect it back to Dr. Schrank's comments, that we have these different pockets. How can we align on that and work together through these very similar areas of research of human factors, health literacy, and usability?
One area is by publicizing case studies where you have seen success, where people have applied human-centered design to any of these products, including their risk communication, and showing that that can pay off in terms of uptake by physicians, healthcare providers in general, by payers. So including payers in all this, because again, you can appeal to, they want to use their money efficiently, and if good human-centered design can improve compliance, like I was mentioning a moment ago, that's better for the payers, it's better for the patients, it's better for everybody all around. So one way is to make people aware by examples, case study examples, that these things have been done, and here's a company that's now reaped the rewards because the payers accept their product more readily over other competitor products. Patients accept it. We get good health, economic, and outcome results from the products that are better human-centered, human-factored design. And so a way of getting those examples out there and more well-known, and potentially adopted by more companies. The regulatory cloud is important, and certainly in the medical device field, until I'd say 2008, before the Human Factors Group and CDRH moved to the Office of Device Evaluation, they were a consulting group, and they weren't required to be on all reviews. Now they are, and I've seen an amazing thing. In my 40 years of being a human factors person, there are companies now who have created human factors groups that never would have, and it's all due to the FDA. Companies, big name pharmaceutical companies never had any human factors people. If they did, they had them in the back office worrying about some software things for the production line, but not about product design. And now I see job ads come across all the time for big and small companies. So it's a great boon for people who choose human factors as a profession. And so the regulatory cloud is not to be underestimated, but I think you can do other things like promote these case studies and examples. Because management, and have business cases to go with them. I guess, well, I'll stop in a moment. There's a book called Cost Justifying Usability. My voice seems to be cutting in and out. I don't know, is that okay? Okay. Well, and then my hearing is going. There's a book, Randolph Pius and Deborah Mayhew, called Cost Justifying Usability. It's filled with little mini business cases for why human factors can pay off. And it's written by people from Ford Motor Company, American Airlines, medical product companies as well. Having those little mini business cases showing the value, their economic return to a company, and having that in your case studies. So for example, many medical products have a problem where you have recalls, or people return the product and don't use it, sometimes because of usability issues. If you can show in a little mini business case that you've put a dent in that rate, say it's originally 10%, now you bring it down to 5%, you can put dollar value onto that increase, or increase in customer acceptance, decrease in complaints, that you compare to the outlay for human factors, which Irene was mentioning is typically small in comparison to clinical studies that have thousands and thousands of people that are conducted over long periods of time. And you could do a rate of return calculation. I've done this for some projects, and it's always astounding because the number comes out very high, and then people start to get skeptical. Oh, you've cooked the books. You know, the numbers don't sound right. But you say, here are my assumptions. You know, make your own, and redo the calculation. So supporting these case studies with economic analysis, mini business cases, I think would bolster them, and that gets the attention of the management in medical companies. Absolutely.
So I would agree, but I think part of, talking about broader reach here, which I think is what your question was getting at, is how do we get other organizations to embrace what FDA has been talking about today, what Ed has been talking about. It starts with this kind of dialogue right here, which is getting the information out, making it clear that the patients, the end users need to be part of this process to really put out medications that we think will be used safely and effectively. And I think FDA has been a big proponent of conveying that message through these forums. But, we sort of talk a lot about, well, FDA has regulations, and of course manufacturers have to follow them, and so on and so forth. But we want to reach beyond that. We're a public health organization. We recognize what's within our regulatory authority, but clearly there are things that are not within our purview as a regulator, which requires coordination and involvement from the rest of the healthcare community and the community that's passionate, and the patients themselves, which I heard this morning in the session, talking about the patient's role in this and their need to speak up and be part of the solutions in driving the solutions. Again, getting at the consumerism piece that was spoken about this morning as well. So certainly we hope in participating with this as an agency that we are driving that message, the importance from a public health perspective of incorporating the end users in the design of these interfaces.
Thank you.
Ruth Parker. So I was thinking about Will's comment about embedding health literacy, and it is absolutely music to my ears to hear the agency talk about health literacy and to think about bringing drugs to market and to hear manufacturers engaged and payers. And what does it mean to think about a health literate look of bringing new products to market, thinking about safety and efficacy with those concepts in mind on the front end. I think we're making progress there. I guess the specific question I have relates to, and it follows it a bit on a comment you made as well. It's in the post-marketing and when the real world use of products that were extensively developed, studied, looked at, when they go into practice, what happens? What happens in the real world with use? And I'm thinking about opportunities to embed health literacy in post-marketing. There's a lot of emphasis, and I think it belongs there, in bringing them to market, safe and effective use. But then in the real world, you get into effectiveness, right? And you get into what happens when people really do it. And I'm wondering what opportunities there are in that to think about a lens of health literacy. Will, you may have thoughts about that, but what does it mean on the other side when you talk about embeddedness? What are opportunities there?
Yeah, excuse me, and sorry I had to leave for a second, just a little emergency came up. I think it's a really, really important question, Ruth. The post-market surveillance research that's generally done is very epidemiologic. It leverages large databases. It looks at rates of clinical outcomes by patients depending on what meds they're taking and what combinations of meds they're taking. And there is very, very little nuance around the patient's experience around how they take their meds. We know there's a lot of heterogeneity in terms of how meds respond in different patient populations, and some of it may be genetic, and some of it may be, there may be a lot of biologic reasons, but I think probably everybody in this room recognizes that there are very important social reasons why in the real world some meds work better than others, and it's not just adherence, it's around just the way in which they they administer the drugs, the way in which they manage their lifestyles. And I think that concept of a much more of a richer patient-centered view of data collection could allow for a much, much richer and more nuanced way of understanding more about safety and efficacy and adherence in the post-marketing surveillance time period. So I do hope that that's something that could be really, that could be expanded on.
So, and I'll speak from a little bit of a different perspective with regards to the post-marketing, which is what are we seeing as an agency, what's happening. So we, within CEDAR, we use a database that we refer to as FAIRS, which is the FDA Adverse Event Reporting System. And what feeds into FAIRS essentially is millions and millions of reports that we're receiving as an agency. So there are, some of you may be familiar, there are requirements incumbent upon manufacturers to report if there's serious adverse events, et cetera, et cetera. These are written out in regulations. So we have obviously a rich data stream coming in directly from the manufacturers. There's also what we refer to as direct reports, which are, any of you reporting, going on FDA's website and saying, hey, I want to fill out a MedWatch form, something's happened to me, whether as from a patient perspective, as a caregiver, as a healthcare provider treating a patient. So that's also another rich data stream. We also have a lot of collaborations, if you will, with other organizations, patient safety organizations like the Institute for Safe Medication Practices, and they will feed in reports as well to the agency. So all of these data streams are coming in, and we are looking at that. So rest assured, we are looking at that. The time you are spending on reporting is valuable time, because this is what is driving, in fact, the guidance documents that I had put up one, for example, that's still a draft guidance, but on the labels and labeling. That is written because we have such rich experience that's reported to the agency about what's happening out there. When these products get out in the market, where are patients encountering difficulty? Where are providers encountering difficulty with understanding? And, part of our consideration, because some of the labels and labeling are really designed more for the provider with the intent that they will take that information and then convey it to the end user, the patients or the caregivers. So if those providers aren't understanding, then that's only going to have a further downstream effect in terms of patient understanding. So we're really paying attention and thinking about that when we're approving these labels, labeling, product designs, et cetera. But there is a wealth of resource that we draw on, and we like to say, or I like to say, that getting a product out into the real world, that is your ultimate validation. Whatever the manufacturers do in terms of simulated testing before they bring something to market isn't going to compare to getting it into the hands of potentially millions of users and then seeing what gets reported to the agency. So the post-marketing is very, very important for the agency and something that we really pay attention to in driving policy recommendations, et cetera.
Terry?
Are you going to speak?
Yeah, I was going to add to that. We live in a great time with technology, social media, for example, giving people and patients and others who are part of the healthcare system a great deal of post-market information. People post things on Facebook, the Twitter accounts. There are websites devoted to certain disease states, and people very readily give their stories. So YouTube, you can find people teaching you how to deal with side effects and the risks of certain medications and therapies with lots and lots of detail. You can get buried, and it could actually, you got to be careful about reading, going through there and checking and getting the good stuff versus the bad. But this is new, that we've had this opportunity to learn so much. And in my family recently, we've had 3 or more health conditions that we felt so enriched by going out and looking at social media sites, understanding the pros and cons of different therapies and alternatives, and what sort of things could be done to prevent some side effects, to ask intelligent questions to our doctors before we made some healthcare decisions. These are things you couldn't do 10 years ago. Now, and then there's the downside of too much information and some of it being bad, but I think on the balance, what we have available to us is a wonderful thing. And I think it makes post-market surveillance even richer because of that.
So my question to all of y'all is a curiosity question. I want you to give me a concrete, specific answer. So what has worked? Like, what was a cool thing that worked at CVS or Abby? I was wondering, what in the hell you told Abby? What have they done that made a difference? And then, Irene, where is that one-page handout that the FDA's been working on for a while? I mean, that seemed like something, but if each of y'all could, is there anything that's specifically, concretely better with this lens of human factors and health literacy that's in the market? I mean, what CVS, I mean, don't get in trouble, but I meant, if it's working and it's out there, can you give me an example?
I can give you a bunch of
Not
examples.
working?
I'll just run through a handful of them quickly just to kind of give you a sense of the breadth of the kinds of interventions. And I don't work at CVS anymore, so this is not a sales pitch. But a whole host of human factors approaches around how patients administer and take their meds. So synchronization of refills on the same day of the month. So instead of making 10 trips to the pharmacy in a month, you can get them all on the same day. For patients with really complex regimens, multi-dose packs, so you get your morning doses all in a single package, your afternoon all in a single package, your evening all in a single package. It gets mailed to you. It's a much, much simpler way to administer a complex regimen. There's a whole lot around.
But those are great. Pick up your drugs, even though they keep changing on the same day. Somebody will sync that.
Exactly.
And then if you've got a lot of meds, have them in a dose pack so as Mike Wolf says, somebody does the math for you.
Exactly. So there's a lot around incentives. We're CVS has created a whole series of incentives around encouraging people to do healthy things. The best example was a recent New England Journal paper that looked at patients that were randomized to different kinds of financial incentives to stop smoking. I know this does not specifically align to medication use, but it's behavior change, and I think it sort of lines up in the same spirit, where so they randomized. There's a factorial design. Some patients were told that they'd get a $700 reward if they stopped smoking. Others they had to put $150 in the bank, and if they stop smoking, they get the $150 back and then an additional $700. And if they don't stop smoking, they lose the $150. It was hard to get patients to make that contribution, but amongst those that did, they were more than 5 times more likely to actually quit. So you sort of leveraging behavioral economics to try to guide these. There's 50 different tests that happened at CVS in the 2.5 years I was there that I could speak to forever. Some of which I think are incredibly cool. Some of which are just so like common sense that you'd be amazed that it never happened in the first place. And there is certainly a huge amount that's happening, and would be happy to talk to you more.
No, that's very cool. So what did you tell Abby? What have they done because of you?
Well, we've had a lot of good successes as a result of human factors being incorporated in product design and its support system. One comes to mind is the biologic Humira, which is a $14 billion a year last year sales, and it has a huge ecosystem surrounding it. It's had a lot of human factors testing, apps that support it, talking training pen to show you how to take the injection, and it talks to you as you go through and you're learning how, creation of ambassador programs that will send people to your home, improvements to the pen and its instructional materials and the training that goes with it, videos that show you. So we have a very low return rate of people not being able to use the injector successfully, and that's a big part of compliance. So that's probably a good example in terms of the major economic impact. But we've had packaging and labeling for HCV drugs that are in the marketplace now, and for complicated regimens of oncology drugs that are oral, that the packaging and labeling design have to be done right to get those schedules understood and used properly by patients, to get the drug to be used safely and effectively. We have an ambulatory infusion pump for Parkinson's people called Duopa that has been subjected to a huge number of usability studies so that it can be used by people who have impairment due to tremor and stiffness, among a long list of products. So the company has embraced human factors and seen the payoff.
Irene, where's that one pager?
I'll actually take that question. I'm here as the representative. Yes, that's what she brought me. So FDA has been working very hard on a proposed rule to require patient medication information for those prescription drug products used, dispensed, or administered on an outpatient basis. As you all are very aware, rulemaking is a very long process, to say the least. But we've been working very hard on it, and we are very excited because we were on the Spring Unified Agenda. So the Unified Agenda lists the actions that agencies are going to take, regulations that we expect to publish within the next year. So PMI is alive and well, and we are looking forward to that. On one of Irene's slides was the link to the Unified Agenda, to the Patient Medication Information Unified Agenda entry.
Let me ask another. Whoops, go right ahead, Irene.
Oh, and I was just going to add that I think, one thing that I would say is working from our perspective is the uptake of the understanding by industry that ensuring the end user, for example, the patient, can actually use the product you put out there is part of FDA's consideration in terms of whether a product is safe and effective. And I think that's been a message that's really we've been trying to drive home to our stakeholders.
Let me ask another question. There was an initial discussion that a lot of this began with Errors Human and Crossing the Quality Chasm. That's 2000, 2001. where most of the discussion was related to institutions, 100,000 deaths, things of that nature. Most of the discussion today, perhaps, has been in the outpatient arena. The outcome of the "to err is human" crossing the quality chasm was that quality is really a systems property. And I don't hear the discussion about these issues within integrated delivery systems. I don't hear it in my integrated delivery system. What are we missing here in terms of translating this discussion to where medication use is a real issue? Will?
Yeah, maybe I'll take the first crack. I'm sure others have thoughts on this. The sort of the sentiment is right. I think that within a hospital, there's a lot of moving parts, and you need to have sort of an organized system in order to address problems related to the complexity of care and reduce the frequency of errors. There's a clearer sense of what the many sort of factors are in a hospital. It's a little bit more of a controlled environment, and nonetheless, it's still relatively hard to do. And there have been extraordinary efforts and great success in terms of doing that. Doing the same thing for patients in their homes is what you're talking about, right? How do you sort of establish a regimen, a system, an approach that allows you to eliminate errors, improve adherence, do all the sort of, really help patients use their meds better. I think the couple things that make it harder are the patient may not always have this, may not always be aligned in terms of what their perceptions are of success. Patients have varying views about the value of their medication or how they feel about their medication, and if the patient at any point is not aligned, that's going to be a very hard thing to overcome. I think the other thing is that there are so many more factors, social factors, that are impacting a patient's decision around how they take their meds at home that are they're very hard to create a sort of a systematic approach that addresses all of them. So things like the cultural, features of taking medication, or the cost features around taking medication, or the unexpected fact that your car broke down and you can't get to the pharmacy, or that your arthritis is acting up and you can't really open your bottle. There's so many more unexpected and really hard to the number of permutations of potential barriers is almost infinite. So the answer is, your question is the right one. The answer is we need to keep creating better systems, and things like multi-dose packaging and things, efforts to simplify and help support patients and engage patients and motivate patients are critical. But it's not the kind of thing where you set out. It's not as easy a checklist to create and then say, oh, the problem's fixed.
Well, let me get a little more specific. You're now at UPMC, and so are you satisfied that in a hospital setting where it's true you have more control, so to speak, that these discussions are ongoing and that you're getting to the outcome that you would like when it comes to medication error, when it comes to transfer of information from the inpatient setting to the outpatient setting, that transition period? Are you satisfied, not only UPMC, but what you're seeing in other integrated delivery systems?
Full transparency, I've been at UPMC for about 3 months. In those
Plenty of time to find out all the issues.
Haven't figured everything out. I do think that I think hospitals have more and more are really adopting a pretty formal approach to improve safety, and I do think my sort of cursory understanding of these very sophisticated efforts to improve quality at UPMC suggests that they've thought of a lot of stuff. I don't know if it's working perfectly, but they've thought of a lot of stuff. You asked a more complex question. What about at the point of discharge when patients are going home? And I think that's where all stuff breaks loose. I think and not just getting the right medicines when you go home. I think that's less of the problem. The bigger problem is reconciling the meds you just got with the meds you already had at home, which overlaps, which do you throw away, which do you keep. We're doing work with, we acquired a company called Vivify, which is a telemedicine company, and we actually do face-to-face medication reconciliations with pharmacists when patients go home. We, at the outset, have had pretty good results. It's relatively new, but I think that this is like, we're far from having this thing figured out. It's something it's going to be a progressive effort to keep getting better.
Does the FDA think we're doing a good job in that setting?
Well, I think, first off, I will say that obviously when we talk about some of the systems considerations for like a healthcare system, that doesn't fall under the purview of the FDA. Although I think a lot of people like to believe we have a lot more authority than we do as an agency. But I think, when we think about the interconnectedness and we think about these systems where you have a lot of handoffs and care from an ICU to a telemedicine ward and then to ultimately to discharge, and then they got to go to the home setting, and how do you deal with that? At least from the agency perspective, within the division that I represent, we think a lot about the entire medication use system. So we think about how that product is traveling through all the different settings of care and whose hands are on it, who's interacting with it, when we think about how we want to make recommendations or what recommendations we want to take. Historically, I think, there were circumstances sometimes where we were really taking more of a reactive approach. We'd get a post-marketing issue that would arise, and we'd say, okay, well, now we're going to go back and fix it. And I think we've really changed our approach as an agency, especially in the last decade and a half since to err is human, in terms of saying, no, we really want to make sure we're taking more of that proactive approach, thinking through the entire med-use system and how things are traveling through it, and identifying those points where there can be vulnerabilities and failures can occur. So that's certainly something that's emphasized now within, especially the division that I work. That's really our bread and butter of what we're doing every day. And to touch I think a little bit on the point that Will was talking about in terms of, wanting to ensure, despite that there's so much variability, obviously, when someone goes home, there's different cultural considerations and other factors, socioeconomic, et cetera. To some extent, though, and I think Ed would probably speak to this more so than even I can, there's a lot to be said for that ethnographic research. Someone was talking about that earlier today. I apologize, I don't recall who had brought it up, but we hope, we expect really that manufacturers are going out there and really understanding their users in their home environments, in their settings of care, to design a better product. And yes, some of that design is going to be about requirements to meet what the FDA wants, right? But some of it is also about just from the public health perspective, how do we put out a better product, a product that we can ensure can be used safely and effectively in the hands of our users and that they will want to use, I think, from the industry perspective. So I think it's really important to underscore that kind of research can be done early in development by manufacturers.
Will, I see a partnership here. Yes, last question.
Dan Morrow from University of Illinois. So I reformulated my question as things have been going along here. I'm hearing a lot about the potential of technology for integration, patient experience, and provider organizations, and the crucial importance of human factors for that. The thing I'm not hearing is the potential for electronic health records to be the sort of the linchpin of that synergy between the home. It's crucial for discharge. It's crucial for supporting medication use. It's a huge problem, as everybody probably knows. Do I have a question here? Does the FDA play a role in supporting I mean, I know NIST and other federal agencies have an important role in thinking about the usability of EHR. But from the health literacy perspective, where you have the potential of electronic health records to support self-care with their healthcare providers, is there any role of the FDA in promoting evaluation from a systems perspective?
Yeah, so for the patient medication information proposed rule, so just to kind of go back to the last point is we think about the patient all the time. That's our primary focus. A lot of us in our office, and in fact our new director, we still practice. So she's still a practicing physician, I'm still a practicing pharmacist. And so throughout both of your roles, you're constantly considering what the patients need, how you can address their concerns, and how we can get that information to the patient. So when working on the proposed rule for patient medication information, we have taken a lot of stakeholder feedback from retail pharmacies who would ultimately dispense a lot of patient medication information, and other different groups that would provide patient information. And we think about all of that and how we can dispense that. And so we work to be flexible with our rule to really focus on not current technology, but to allow for flexibility in the future. And we've spoken with a lot of stakeholders in EMR, in different software development, in different apps, and to make sure that we're flexible for the future. So we definitely do take it into consideration.
Ted, I may have cut you off on the last.
Yeah, I modify my answer a little based on the second question, but if you want to get ahead at a company like AbbVie, or which is a startup company in a sense, although it had a 100-year history from Abbott before it was spun off, you need to embrace ecosystem of how our products fit into the patient journey. So there are a lot of projects that involve looking at and mapping, and we have meetings where you look at the patient journey from diagnosis to original prescription to titration, maintenance, and hopefully cure or stable conditions. That's all laid out. Where do we as a manufacturer fit into that? What can we do? What kind of things could we develop? Training materials, more information, doctor aids, to help enhance the patient journey, and looking at what we call the ecosystem. So if you want to show that you embrace the values of this relatively new company, this is true for people I speak to at many other companies, these are the things you need to embrace. And that includes, where does this integrate with electronic health records? What do we do with our systems, those parts that have electronic components, and more do now with supporting things like apps or websites. How do you integrate that with electronic health records in a way to improve the patient journey?
So I would just add one quick thing. I think it's a good question, Dan. To build off Ed's comments around, you really need to understand the workflow. The folks that are making phone calls to patients and trying to engage them about their medication use generally aren't the doctor. They're often other folks on the staff. And I guess everybody has a different set of tools, but for us, we have a care management tool that does interact with the EMR, but it's the tool that's being used is a care management tool. It's a tool that's being used by care managers, by nurse practitioners, by allied staff, by pharmacists to try to manage patients, coordinate their care, manage patients over time. So for us, it's not an EMR thing. It's finding sort of the right place within the workflow that delivers the right information to the person that's going to do the outreach.
So thank you very much, Ted and Elizabeth and Irene and Will. This has been a really good...
I just have one.
Oh, I'm sorry.
I just have one quick
No,
question
go
and
ahead.
comment. I just wanted to first, the patients never get to really see, obviously, the people who are responsible. So, of course, this is a great opportunity for us. And I know it's not easy on your end. I really know now as a patient. But hang in there with us, you know. I know that everything that you have in place and what you're working with, you only get criticized mostly. And it's a patient type of thing, and they're all evolving and they're different and things of that sort. So I did want to say that, because there is no easy way to do this. But I do know also as a nurse that discharge planning starts upon admission. However, you have all of these different entities involved in a person's care, and so it is quite difficult to navigate through those things and get to the bottom without rushing toward the end when everything comes back to the medications in their life. I do want to say that if we keep things simple, because this is bureaucracy of complexity. It just is, especially on you guys' end. But the simplicity is what really works and what enables the patient to continuously feel empowered. So something as simple as this drug may cause decrease in blood pressure, a link, a resource there so that the patient can realize what that exactly means, what those signs are. Okay, because it's something that is as simple as that can help the patient become more empowered and involved in their care, and then they will have something more to contribute. And I know this now as a patient, as opposed to being a nurse and saying that to patients over the years. But when I kept having issues, for example, taking labetalol, clonidine, and hydrazine, and it's a dialysis day. Well, you have to take your meds with meals. What does that exactly mean in terms of with and simultaneously or beforehand? But if I have a 6-hour dialysis session and my time is 10 a.m. or 9 a.m., so to speak, and I have to take a meal before that or with meds, can't eat while on dialysis, and then I started noticing that I'm bottoming out because I'm only 120 pounds taking 200 milligrams of labetalol every 12 hours, plus clonidine, plus hydrazine. So, but if I would have known, well, these are the signs and symptoms of such, until it kept happening and the staff didn't know. But now within myself, I'm like, wait a minute, I'm getting flushed. I'm getting diaphoretic, just like this. Are you a diabetic? No, I'm not. What's happening? And then I'm getting off the machine because I have a fight or flight response in my body that's saying something's going wrong. And I'm articulate and can communicate that, but what about the person that can't? They're just getting rushed out and, transported someplace else. And so through my research, I follow you guys, Twitter, Facebook, and things of the sort. And I'm often just putting stuff up like most patients, wondering and hoping that it'll go somewhere. But if you have a place or you start to implement a place where more resources where patients can reach out, and a bank where they can put that information and know that it'll be followed up with, other than a complaint, because let's face it, when you get the patient's attention, it's because it's a class action lawsuit and they're hoping they can get some bucks. It's terrible. Even that's when the family members say, you have a problem, that's when we get it. You're just like, no, but every other day, we would like the same type of options positively that can help your job be a little bit more easier and our job more feasible. I'm a patient. This is what I have to carry to travel. A PRN side and a day-to-day side, praying that nothing happens, but it was never a part of my care. Or if I get transferred somewhere, someone to ask me, what is that you carry? How do you travel so much? What do you do with your medications? How are they stored? And how is it feasible for us to help you in that part of your life? So just consider it a patient. And thank you for all that you guys are doing. I appreciate it.
I just wanted to say one thing in follow-up. We really value anytime patients can provide us with information on what they need. It really does influence what we do. And we even have patient groups in, it's OGA, I don't even know what that stands for. But the office, they work with a lot of patient advocacy groups and patient rep groups. And we really utilize those. So even when we get inquiries from out of the Division of Drug Information, DDI, it really influences what we do. So I encourage you to continue contacting the agency, contacting OGA, contacting DDI. And even just sending it to our mailbox. Ours is the patient medication information at FDA. But definitely contact us because it does matter.
Thank you very much for that last question. Once again, thanks for a very stimulating panel. Once again, it engendered a lot of questions and also some future opportunities for the roundtable. Much appreciated.